So, welcome everyone. My name is Cora Peck. As you may know, I'm on the board of directors for the Pudendal Neuralgia Association, which is a nonprofit. I am joined today by Dr. Kenneth Peters. Dr. Kenneth Peters earned his medical degree from Case Western Reserve University School of Medicine in Cleveland, Ohio in 1991. He completed both his general surgery and urology residencies at Beaumont Hospital in Royal Oak, Michigan in 1993 and 1997, respectively. Dr. Kenneth Peters is a distinguished urologist and academic leader based in Royal Oak, Michigan. Since 2008, he has served as the professor and chair of the Department of Urology at Oakland University William Beaumont School of Medicine and as chair of urology at Corewell Health William Beaumont University Hospital. We're so glad you could join us today. And to get things started, we will start with a little bit more of a generic approach towards pudendal neuralgia. And we are just curious, how is it in your clinic that you diagnose pudendal neuralgia? What specific tests or imaging techniques do you use?
Yeah, thanks, Cora, for having me, and I appreciate the opportunity to speak to your members. It's been a journey for me because when we trained in medical school, no one knew about the pudendal nerve or pudendal neuralgia or causes of pelvic pain. Anybody who hurt from their belly button to their knees had interstitial cystitis, and that's what people just labeled it as. And it really has been an evolution of understanding the role of the pudendal nerve, the pelvic floor, hormones, all those other things that impact pain. Sometimes it's really easy to diagnose pudendal neuralgia because I walk into a room of a new patient and they're standing, and I already know why they're there then, right? Because there are the classic criteria for pudendal neuralgia, the Nance criteria, you know, you know, pain in the distribution of pudendal nerve, worse when you sit, better when you stand, doesn't typically wake you up at night, and then responding to a diagnostic pudendal nerve block. And that's kind of the classic criteria that one would use for that. Not everybody presents in a classic way. And if you remember, the pudendal nerve comes off of the sacral nerve roots, S2, 3, and 4. But there's 3 branches of the pudendal nerve. So it goes to the dorsal genital branch. So it could go to the clitoris or a man in the penis. There's the perineal branch, so vagina, urethra, bladder, pelvic floor, and then the rectal branch. So either a specific one of those branches or all of those branches can be involved. So somebody might present with symptoms everywhere, in their genitals, in their perineum. They feel like they're sitting on a ball. They have rectal pain. Sometimes it triggers with bowel movements and things like that. So, initially it's getting the history, like how did this start? When did this start? What, I'm big in letting patients have a chance to talk. Like what do they think triggered it? Because you learn way more if you give the patient some time to tell their story, and they have a lot of insight into it. And, you'd like to think that there's just somebody says, oh yeah, I fell hard on my tailbone and ever since then I had it, or, was after childbirth. But a lot of times it just happens, there's no distinct injury. If it's an injury, then it's easier to sort out the issue over time. But if there's no injury, it isn't. So it's really understanding, the evolution of the pain, how the pain presents, what makes it better, what makes it worse, what collateral things are associated with it. Like, does it affect the bladder? Does it affect the bowel? Does it affect sexual function? Is there genital arousal associated with it? Because all of that can be part of the pudendal nerve, and all that can happen without the pudendal nerve. So it isn't all pudendal neuralgia, but understanding kind of where the pain is, and then what triggers it and what makes it better, that's very helpful. And we talked about, sitting and lying, and, most patients with, significant PN, I mean, they don't like to sit, or if they're sitting, they're carrying a pad with them everywhere they go, or like their toilet seat is their happy place because, there's no pressure on the pelvic floor. But it's getting that initial history, and then understanding kind of what they've done from that time, because that helps too. A lot of times, like I said, patients come with a diagnosis of something, and I'd say, and we see patients from all over the country in our multidisciplinary center, 85% of the time we changed the diagnosis of whatever they came with. It would, and probably the most common is interstitial cystitis. But as I go through this, process of getting a good history, then it's a physical exam. And basically, a good, exam, I always, you think about like the area of the tailbone, the spine, do they have any back issues? The a good genital exam and like Q-tip test, is the vestibule sensitive, because that clearly can be pudendal nerve. A good exam of the pelvic floor. And to be honest with you, when I was a medical student and a resident, nobody examined the pelvic floor. I mean, no one even knew what it was. And so now we put on courses, we try to teach people about the importance of it. But as you do a pelvic floor exam, it's not only like, is there pain? Are they in one, one quadrant, more quadrants than one? Are they one-sided or bilateral? Because I mean, sometimes pudendal neuralgia is just left side, or just right side, and sometimes it's both. But then on that exam, I always like to feel the ischial spine, because that's where the pudendal nerve comes right off. And a lot of times if somebody has pudendal neuralgia, you kind of poke the pudendal nerve and it triggers them, and I always tell my residents and fellows, do that exam on everybody who doesn't have pain. So see how people respond who don't have PN or don't have significant pelvic floor dysfunction. But that gives you one more sense of is that what's going on or not. And then a lot of it is, has the patient's done what I consider standard things first, pelvic floor physical therapy, but did they go with the right therapist who isn't teaching them Kegel exercises and more the relaxation? And are they doing internal work to manipulate and free up the nerve and free up the muscles? What what medications have they had? Have they had nerve blocks done? And if they've had nerve blocks, what has been blocked? And the other important question is, like, I've had people come and like, oh, I had a pudendal nerve block and they didn't do anything. And I'm like, well, were you numb afterwards? And they're like, well, no. And I'm like, well, then they missed the pudendal nerve, So it's not only did they have a block, but was the block effective in creating at least numbness? Now, if you have, and so I tell patients, a block like pudendal block can be diagnostic and therapeutic. But I like the first block, because if you can do a block and they get numb and their pain level goes down significantly, I at least know the pudendal nerve is driving a significant portion of that pain. If I do a block and the pain is, they're numb, but their pain is no different, then it's coming somewhere else. It's coming probably higher up. So it's putting all those pieces of the puzzle together. But if they have the classic Nance criteria we talked about, and they have a diagnostic pudendal nerve block, and they fit kind of the story of the pudendal nerve, clinically, I'll use that as a starting point for things. I do imaging. I do like, MRIs of the pudendal nerve. So we do really thin cuts. We have one radiologist who reads those for us. 99% of the time, they're normal. And you're doing it to rule out that small percentage where there actually is something. Somebody has some mass or cyst in their pelvis compressing, maybe have Tarloff cysts that are compressing along the sacral nerve roots that may be impacting it. But I don't image everybody right off the bat. I'll usually kind of start treatment and decide along the way if I would image them. So that'd be like my first approach at it.
Okay. And for those people that do have more than one diagnosis, for instance, you mentioned IC or pelvic floor dysfunction or even PGAD, how do you decide what to treat, how to, or do you just go at it as a full, because you said multidisciplinary
yeah.
approach, right?
I mean, it's a great question, and it's so tailored to an individual who comes in. But what I would say is that if somebody comes with the diagnosis of interstitial cystitis, there's one for sure interstitial cystitis. That's somebody who has ulcers in their bladder. But that's the small percentage of people, and that's how it was first diagnosed, truly a bladder disease. And if you do a pelvic floor exam, or the pelvic floor isn't being driven, pudendal nerve is calm, they're not worse when it's a bladder disease. But if somebody has a bladder dysfunction and pain, is it the bladder or is it the pelvic floor and the pudendal nerve? And I always say I treat that first if they have any pudendal neuralgia, pelvic floor issues. And if their IC goes away, then it wasn't IC, and that's most of the time. Like the bladder is an innocent bystander and what's going on around it and not really driving this. PGAD there's a bunch of different things. We published a paper a few years back, like a huge paper that was a whole group of us from all over the world, and talked about all the different triggers for PGAD. So for some patients, it is the pudendal nerve, and we publish papers on, treating the pudendal nerve with neuromodulation or blocks and stuff like that that help PGAD. But for other people, it has nothing. It's more central. It's a peripheral nerve. It's higher in the spine with Tarlov cyst. So again, if somebody has significant PGAD and part of my evaluation is a pudendal nerve block and their PGAD gets better, well, I'm feeling pretty good that the pudendal nerve is driving it. A lot of times with PGAD, and I've seen in men and women, who sit a long time, it's worse. I've seen men like truck drivers who get this and it's really bad. I just was in my clinic and just saw a man with terrible PGAD. So it can happen in both. But again, not always the pudendal nerve, but it's in that differential. So it isn't like you can separate all these things out from each other. They're all interact with each other. And there's other things that you got to think about, right? Irritable bowel issues or bowel issues in general, endometriosis, other things. And it isn't that one person just has one thing always, although you like to think of the one thing that might explain most of their symptoms and target your treatments to that first. And the center we created, I learned a long time ago, if we stay, like, if you see a urologist, it's interstitial cystitis. If you see a colorectal doctor, it's irritable bowel. If you see a gynecologist, it's endometriosis. If you see a rheumatologist, it's fibromyalgia. But the fact of the matter is the best thing to do is look at the whole person and look at all of our disciplines. So we put a center together with, urology, urogynecology, gynecology, colorectal, pelvic floor physical therapy, pain psych, integrative medicine, all under one roof to be able to evaluate. Like, we're a big mind, body, spirit group, look at the whole person and try to figure out what areas might be triggers, and then how do you chip away at those triggers.
That sounds wonderful. I should go. So for the people who do not respond to conservative treatments, like you mentioned, some of those earlier physical therapy, medication, when do you make the choice to take a step further, and what are some of those options that you offer?
So, always we'll do a series of pudendal nerve blocks, and whether we do them transvaginally or I have my anesthesia pain docs do transgluteally, depending on the patient. In the men, for sure, I do transgluteally. In the women, I do most of them transvaginally because it's simple. I could do it on the fly in the office. But if they get benefit, but it's not prolonged, then we also, we do pudendal nerve, radio frequency ablation. We, not me, but my anesthesia folks. So sometimes we'll go down that route of just seeing if we can, send a high radio frequency to the nerve. And it doesn't ablate the nerve. I hate that name, but it suppresses the nerve from firing as much. And that could give prolonged benefit for some people. You get 6 months, 12 months, 18 months of benefit. May still need to be done again, but it also could just fail completely and not do anything. But it's one of those one more kind of more advanced things to try. And if you've gone down these routes and nothing is really moving the needle consistently, I mean, that's when, I bring neuromodulation into the mix.
Okay. And speaking of neuromodulation, could you explain how neuromodulation works for treating PN and how it helps to manage symptoms?
Well, I wish I could tell you how it works because, although like Interstim's been around for overactive bladder since 1997, it works amazingly well, but we still have no idea why it works other than changing signals centrally. So if the pudendal nerve, so again, the pudendal nerve comes off of the sacral nerve roots, right? So Interstim, in its traditional sense and how it was developed, is placing an electrode at the sacral nerve root to override abnormal signals. And, the studies were initially done for overactive bladder, then fecal incontinence. But there's dozens of papers on benefit of, from chronic pelvic pain, pudendal neuralgia specifically or not, it hasn't been honed down that much, but in general, improvement in pain to the point where we just got a multi-million-dollar grant from the NIH to study sacral neuromodulation for that. Because if the sacral nerves become the pudendal nerve, you're interrupting signals. So we did a study years ago in 2003, we published in 2005, where we gave patients a sacral and a pudendal implant, and they externalized them both, and they randomized which one got turned on first, and they didn't know which was what. It was lead A or lead B. And then we trialed them for 2 or 3 weeks, and then we unblinded it. And what we found is that 80% of patients did better with stimulating the pudendal nerve with sacral, whether it was for, bladder, bowel, or pain, pudendal worked better. Um, Unfortunately, it's not approved for that, and so we kind of developed an approach to place electrodes at the pudendal nerve and published multiple papers on that to treat patients with um, pudendal neuralgia for sure, but also even sacral failures. Even if you're getting sacral for kind of on-label stuff, we showed that 90% of the time, if sacral doesn't give patients the benefit they want, that if you drop a pudendal lead, you can improve those symptoms. The thought is that it's working by changing the central processing at the spinal cord in the brain. So if you place an electrode at the pudendal nerve and that nerve is firing all these pain signals, then if we override those signals, that the brain doesn't perceive that pain, and then over time that pain tends to dissipate. And if somebody responds well to pudendal, there's often a carryover effect over time. So it's not like you always have to stimulate. So like one of the stimulators we use, which is called Curonics, you have to put an external device on the skin to activate the internal lead. It's kind of cumbersome to wear that 24/7, where if we're using the Interstim device, it's got an implantable battery, so it's just doing it behind the scenes regardless. But in general, there's a carryover effect. So when somebody gets better, it becomes personalized medicine. And so that tells me that we can actually change signaling, between the nerve, the brain, and change the outcomes. And honestly, over the years, I've had a number of patients who came in and we put these in, and they're like, oh, I'm doing so great. And I test the system and it's been dead for 3 years and they didn't know, but something over that time just changed. And the nerve just got better and settled down, and they thought they were being treated with it, but no longer were.
Oh, wow. Um, and so I know you brought some to show us.
Yeah.
Would you be able to kind of show us what they look like and talk a little bit about the lead placement and the battery size?
Sure. So the one I started doing first is really the traditional off-the-shelf Interstim device. And the Interstim device is looks like your kind of typical pacemaker you'd put here at the heart. And it's improved dramatically. I did my first one in 1998. I did my first Pudendal in 2003. But the device used to be a lot bigger. The battery only lasted 3 or 4 years. The device is smaller. The battery now lasts 15 years. It's now fully MRI compatible. And so this is the brain of the device. So this is what sends the signals. This is what we program to stimulate the nerve in different ways to try to override these abnormal signals that are coming up. So when we do this device, and I'm going to do it at the pudendal nerve, what we do is we trial it outside the body first. And so what we do is a patient would come into the operating room and they're in like a twilight sleep. And they're on their stomach. And we use some x-ray to map out the area of the pelvis. And then we put EMG electrodes to measure nerve conduction, like in the anal sphincter, because we talked already that one of the branches of the pudendal nerve is the rectal branch. So if you stimulate the pudendal nerve, then you're going to see nerve activity through the anal sphincter. So besides seeing like an anal wink, the motor response, we can see a nerve response. And when I do it with the Medtronic device, we're coming not at the tailbone like you would with sacral, but we're coming down low by your ischial tuberosities, your sit bones. Like we always tell you not to sit on a bike seat and stuff, the things that compress that area. And so if this is the anus, we come, lateral to the anus, between the anus and kind of your sit bone. And that's called your ischial-rectal space. And so that space really has nothing in it as far as any major structures. But, kind of God gave us the ischial spine as a nerve target for the pudendal nerve, because the ischial spine is a very distinct kind of sharp bony structure on the pelvis. The pudendal nerve comes over, and that's your sacrospinous ligament. And so we can see that on x-ray, and it's like an angle. So we make a tiny little, we advance a little needle through the skin after numbing it up towards the pudendal nerve while we're stimulating, and then we're coming up towards that spine under x-ray, and what we're looking for is an anal wink and a nerve conduction. Once we see that, at least we know we're at the nerve. And then it's about trying to get it to go along the nerve itself. Because what you don't want to do is you don't want to cross the nerve, because then you're only one of your electrodes is touching it. We want to lay it along it. So then it's a little kind of like, I call it trolling, coming in at a little different angle, little deeper, shallower, and just make sure that if I go deeper and shallower, I keep stimulating the pudendal nerve. Once I know I'm along the course of it, because these electrodes all have these leads all have 4 different electrodes along them. So if you could stimulate different areas of the nerve depending on which electrode you turn on. So if I could get all 4 of them along it, I could turn these 2 on together. I could turn all 4 of them on. I could turn these 2, and I could manipulate the program that might give them the best solution for it. And so basically it's a skin nick to put that in. So we do a little skin nick, we place an electrode, and then what we do is we pick a site where that future pacemaker could go if this helps them. And so and that's in the upper buttock. So, kind of not where you're sitting, but up higher. And we make just a teeny tiny incision up there, like a 1 centimeter incision, and we tunnel that lead that we put in down low where you sit underneath the skin all the way up to that little incision, and we connect it to a temporary wire that we bring out the opposite side. So let's say I put it on the left side, it'll come out the right side with a temporary wire. And then they go home with an external stimulating thing. It looks something like this. It's like an external pacemaker. They have a wire coming out of them. There's a clear bandage over their butt cheek. And, we let them shower the next day. And what we do is in the operating room, we do different programming based on nerve conduction. So since we can monitor the nerve, we can see if we stimulate different areas of the nerve by touching the different electrodes, we can see which areas gives us, the best stimulation and what milliamps or voltage it needs to activate the nerve. So that helps us afterwards to say, we need to get up to this threshold to know that we're actually activating the nerve. And basically those teeny tiny incisions are closed. There's very little pain with it. They go home with a bandage, and they test it outside their body for 2 weeks. And so they go home with a belt, an external device, and monitoring all their symptoms. So their pain, their urgency, their frequency, their bowels, because it often helps many things. And in those 2 weeks, it's like either it's going to help significantly or not. From an insurance standpoint, with any type of nerve stimulant, they want to know you're at least 50% better. So, we see them back. Usually our nurse practitioners will see them back, or our PAs, and they'll evaluate them and document benefit or not. In that time period, we're working with them, making changes with them, and trying different settings to see if we kind of hit on the best setting that can work. And but one thing I always caution people, because people do this to me all the time, like more is not better. Everyone always thinks like, well, if this is helping me, if I turn it up higher, it's going to help even more. And that's not true with neuromodulation. You turn it up to where you just barely feel it. And when I say feel it, what women and men feel is they feel like a tapping or vibrating, typically in the rectal area, vaginal area, clitoral or penile area in a man. And you turn up where you barely feel it, and then you leave it there, and you'll quit feeling it usually within minutes to an hour. And you're supposed to quit feeling it. But some people want to just turn it up all the time because you always get used to it. But then it's going to have the opposite effect. It's going to cause more symptoms, because if you turn it up high enough, it spasms your pelvic floor, irritates the nerve, and all of that. In that time that we're testing is the one thing I caution patients a lot is you got to be very careful. And it's not going through the sacrum like Interstim does for incontinence. So all there is soft tissue down there. And so you got to be careful you don't plop down hard in a chair. And most people with PN never plop down hard in a chair. But, get in the chair gingerly and get out of it. Don't bend at the waist or do crazy yoga stretches or twisting for about 6 or 8 weeks to really let it heal, because there is a little increased migration rate of the lead away from the nerve if you put it at the pudendal nerve. So, you got to, walking's fine, up and down stairs fine, light exercise is fine. And then I tell people to test it. Like if they never sit, I want them to sit, right? Because that's how is it making a difference for them? And in the end, I always tell patients, if you're convincing yourself you're better, you're not better. Like if you're going, oh yeah, maybe I'm a little better, it's not working. When it works, people go, wow, like this is a good thing. And then if it doesn't help them, well, we got come back anyways 2 weeks later to the OR, a little sedation, we pull out the lead. If it does help them, then, we implant the little pacemaker, and that's just that little butt cheek incision we make a little bigger, create a pocket, tuck it underneath the skin, take out the temporary wire, plug in the permanent wire, and, do some programming, and patients get taught how to use their own programmer and do all this different stuff. So, it doesn't help everybody, and it's incredibly effective for overactive bladder. For pain, we have about a 70%, 75% like test the implant rate. But it's hard to make anyone 100%. I don't have one of my patients is on right now, but I have one out there who talks a lot, who I did make 100% better. And I always feel bad because that's what everyone wants. But, we're looking for meaningful benefit, right? And then hopefully over time, it can get better and better. So that's how I first got into pudendal neuromodulation. That's the Interstim device that we kind of modified to put there. And, like I said, it's been a very successful approach with that device. So I'll shut up there because I have my other device I want to talk about, but see if there's any other follow-up with that.
So
Can't
just,
hear you, Cora.
uh-oh. Can you hear me now?
They can't mute the boss.
Uh-oh. Oh no.
I can hear you fine, Cora.
Okay. Uh-oh.
Uh,
Can you hear me, Dr. Peters? That's not good.
Can you hear me talking?
Uh-oh. Hold on just 1 second, everyone.
yeah, I wait, maybe, hang on. Try again.
Can you hear me now?
Oh, yeah, I can't. I don't know. It must have been on my end.
Okay.
Because I was, yeah, I just moved my little speaker cord and now I could hear you. Sorry.
Okay. No, we're good. Okay. So, where were we? Oh, right, with the implants. I just want to make sure. So, what about those people that do get it implanted permanently? And then let's say 4 or 5 months later, let's say they're like, oh, this isn't working. Do you remove them?
I mean, we will remove them. I'll try not to have anyone remove them in 4 or 5 months. I mean, there's
Right.
lots of programming options that you can do with it, and I'd rather go through all of that. But if something was like, if we're putting it in, we're putting it in because it helped. If it isn't helping, then you troubleshooting, right? So you test the system, and you can place, you could test the impedance, make sure there's no break in the lead. You could try different programs, and a lot of times we'll get imaging again and compare it to what it was when we put it in, and make sure the reason it's not working 4 months later is because it had moved or migrated, or that there's a break in the system that we need to fix. So, but I certainly can take these out and will take them out if somebody wants them out. Because like I said, nothing helps everybody forever, but when it does work, it can be a pretty remarkable improvement for people.
And what if, and I don't know how likely this is, but what if, let's say, someone gets symptoms, like new symptoms? Do you ever adjust the leads after new symptoms appear, or do you go in, say, and do other forms of treatment to see if those help first?
Like new symptoms being like some other
Like
type of pain, or
yeah, some other pain. So like let's say they were usually feeling your typical PN pain, but then now they're feeling bladder pain or something like that. Could it be adjusted to help
yeah.
or
So the only way to adjust is to change the programming, like, because
okay,
really you're putting it at the pudendal nerve, and it's the pudendal nerve, because it's a mixed nerve, motor, and sensory, and there's 3 branches to it. You can't like select, oh, I'm going to just stimulate
right,
this one part of the nerve for this patient, because you don't see the nerve. You're not dissecting it out. It's not like an animal where we could stimulate each little axon in there to see what happens. So as long as we're actually stimulating the nerve, and so what we will do is test it sometimes, because people might feel something and but they're not getting a response anymore. So we could actually do EMG right in the office, where we can see that we're actually activating the nerve, because maybe it did move and it's stimulating their pelvic floor, and that's what they're feeling, but it isn't doing nerve stimulation. So there is some troubleshooting we do. But anytime you take any of these out, if they've been in a long time, there's a risk of that lead breaking when you pull it out, because it can actually really get in there pretty good. It doesn't hurt you if it breaks, like it leaves a little piece there. It's no different than having a clip in your gallbladder if somebody had their gallbladder out. We try not to break them, but it can. I've never seen anyone have any like worsening symptoms taking it out. The only time I've seen that is when somebody says, "Oh, this isn't working for me." I'm like, "Well, have you shut it?" Because I won't take it out if they don't shut it off for 3 months, because there's a huge carryover effect. And I have times where people said, "Oh, I've had it off and it's not doing anything." I take it out, and then they're calling me like 6 weeks later, begging me to put it back in again, and I'm like, I just took it out, but they didn't realize it was helping them, because you
Right.
readjust in your head a little bit. Like your 8 out of 10 pain goes down to 3 out of 10 with the device, but that 3 becomes your 8. Like your brain has a
Right.
perfect way of resetting things. So sometimes you got to remind people what the 8 was, and even though they're still not maybe where they want to be, they're a lot better than they were, or if you took it out, they'd be a lot worse than they currently are.
Okay. And then for the permanent one, is there a recovery time after the procedure?
I mean, not a whole lot. I mean, other than being careful as far as like we talked about, not, sitting on your
Lifting.
butt or falling on the ice or whatever. Because most people have minimal pain associated with it. Most people, if they take anything, they take some Tylenol or Motrin afterwards. We try to avoid things like opioids if we can, because then they constipate and that creates a whole nother thing. So the recovery is more just behaving as much as you can until the body has a chance to lock it in place. And then it's just, trying different settings. And the bladder and bowel stuff with neuromodulation gets better quick, like within a day or two, you can see a difference. Pain takes longer. I mean, if you can get pain significantly better in 2 weeks, that's a good thing, but it can continue to improve over time. So if somebody says, "Oh yeah, well now my pain it was a 8 and now it's a 5, but I really want to be a 0, but a 2 or 3," that they may generate a 2 or 3 as you continue to stimulate over time. So I would encourage them to go on to the implant if they're seeing kind of a meaningful benefit for them in their pain.
Okay. So far that's all we have. So if you want to talk about your other one.
Yeah, so the other system is called Curonics, which was initially StimWave and it got bought out. Curonics is a device that's different. It's number one, it's approved for pain. Now, we're the only place in the world putting it at the pudendal nerve. I did my first one in 2016 with their device. What Curonics is used for, what it got on the market initially for was for spinal cord stimulation, so people with back pain, leg pain. Um, but it's also used for peripheral nerve pain. So if somebody has brachial plexus injury, if they have a failed knee surgery, if they have diabetic neuropathy in their feet, you can place this device almost anywhere in the body, because unlike Interstim that has that pacemaker that you got to put somewhere, Curonics doesn't. Curonics just has the lead, and inside the lead is a little computer chip. And so with the Curonics device, we can place that at the pudendal nerve, but the way you activate the device and the way we tested initially in the operating room, it's the same setup. I mean, you're on your stomach, we're using EMG, we're using fluoro. The difference is, instead of going in that ischiorectal space like I do with the Medtronic device, you go, I go through the sacrotuberous ligament, so transgluteally like a pudendal nerve block. Not my favorite way to go, but the reason I do it with this device is because they don't have a longer lead. Like the Medtronic has a long lead that reaches up to your upper buttock where I could actually put the pacemaker. This lead is shorter, so I can't go below and run it up. Otherwise, you got to like sit on to its energy source. So we go transgluteally like a pudendal nerve block. Reason I'm not as happy with it is you can never get completely parallel with the nerve, because the nerve runs like this and you're coming down like this. So you'll pick up the nerve on a couple of electrodes, but not on all of them. In the end, you only really need one probably good electrode, because like you had just asked before, like, can you tweak it or move it someplace different? What you're really doing is you're depolarizing the nerve. You're hitting the whole nerve when you put a device next to it. So it's different measurements we use with x-ray, and we go through that sacrotuberous ligament, that ligament that they go through to do pudendal nerve block with their needle. And so we can, we numb the skin, we go through there, we stimulate the needle until we see the pudendal nerve again, and then we pass a little wire, a dilator, and then drop this lead down there. And once we drop the lead, um, and place it at the pudendal nerve, to activate the lead in the operating room, and what the patient has to do at home is there's like an antenna that the patient puts over their skin where the lead sits. And then there's external stimulator that you can charge in your wall socket or in your computer. And this is what's programmable. And so this allows us to set different programs. Patients can go up and down and change different settings. But by putting this over the skin, the first thing we do is have the patient go up to what we call a power level. And we measure that in the operating room. We know how many clicks it takes to get the power through the skin and actually turn on that computer chip in the lead. So it's pretty high tech. So you got to get the power through the impedance of the skin. You turn on that computer chip in the lead. When that kicks on, then we can Bluetooth it with an app on our iPad to manipulate the settings and test it in the operating room and do similar things. See, what milliamps it takes to activate the nerve, what lead combinations seem the best. And we record all that and we use that for kind of post-operative programming. Just like Interstitial, you have to do a trial because insurance won't pay for something without a trial. And a couple of caveats about curionics or any nerve stimulator for pain, and this includes back pain, is to get approval for this. You need to have a letter from a pain psychologist or psychiatrist saying that that you suffer from chronic pain and that essentially that you're emotionally stable enough to undergo an implant. Because the concern is by the government and the insurers is if somebody thinks of this as their last chance, and it doesn't work for them, are they going to jump off a roof? So it's like, is the patient in a good space to know that they're going to go through this trial and the trial may or may not work? So we need that just to even submit for insurance approval. Don't need that with Interstitial because Interstitial is not really approved for pain. Second thing is because this is approved for pain, it can deliver the current differently. Where in Interstitial, there's different variables. It's not only what lead combinations you stimulate, but there's something called the pulse width, how wide you make your current and how narrow, and both devices can do that. But then there's something called the rate or how fast it stimulates. With the Interstitial device, like a standard rate that we put in is like 14 hertz. So it goes 14 pulses per second. It can go up to like 50. If you go any above that, like the most it can go is like 100, but it really chews your battery then. Where this device actually can go to like 1,000 hertz. So it can go super high stim. So for pain, it's been shown, like for back pain and other pains in the body, that some people do really well with a super high stimulation because you don't feel the stimulation because it's so fast, and it creates a field around the nerve that is, if you imagine it being like almost like an electrical pain block, it'd be like having a pudendal block, but with electricity. And so some patients do well with the low frequency, some people do well with the high, and those are the things that we trial in that period. Unlike the Interstitial device where I said, we place the electrode, then we come back and place the battery. This one, since there's no battery, what we do is we have to place the electrode and then we just tape it to the skin. So you go home now with another plastic bandage on you. We tape the antenna right to your back. We send you home with this and do different programming. And patients just keep it on 24/7 because it's already kind of stuck to them. And then we see them back in the office, typically 7 to 10 days, and document whether it helped them or not. But unlike Interstitial, where I could place the lead and use the same lead I placed, let's say you get a great response with this electrode. What do I have to do? I have to pull it out. And that it's easy, it doesn't hurt to pull it out, but then you got to go back and do it all over again. And because then you got to put it in, and then it's tunneled underneath the skin, so everything's inside of the person except the energy source. And that is always frustrating for me because like if you get a good lead, you hate to burn a good lead. But this is just the insurance world we live in. So, we'll go back once we get insurance approval for a permanent implant. We go back to the operating room, we do the whole procedure over again, and we place the electrode. And now they're placed literally through teeny tiny skin nicks, usually 2 or 3 of them to tunnel it up. The other thing with this is you can do bilateral stim. With the Medtronic device, there's only approval for a single side. Like the insurance won't pay for both. Where for these like stimulators like this, the insurance company, can pay for both. The insurance company can do both sides, and so it allows us to treat both sides. In the real world, you don't need even if you have bilateral PN. the nerves all coalesce at the level of the spinal cord anyways. So you could treat one side and have benefit on both. But I have to say, I have some patients who I've put in like the Medtronic device and say I put it on their left side, and they're like, oh, my left side feels great, but I'm having still too much pain on my right side. But I'd say more often than not, when it works, it's working for the bilateral pain. And if somebody has pain only on one side, you put it on the side of the pain.
And then what percentage of patients do you see significant improvement with their symptoms for chronics?
Yeah, so we published a paper recently on that. It was like around 75% of patients will go on to the permanent implant. But your point you brought up before is how many people get long-term benefit, and those are things that are variable. I mean, I have some patients that, because with chronics, because there's not an implantable battery, what happens is we test it just taped to them and it's on all the time. Then when we put it in, we usually tell patients, look, at stimulate while you're awake, 10 to 12 hours a day, take it off at night, charge the little thing, and then put it on the next day. But when people get better, what we do is we have them start weaning down how much they stimulate. So I have patients I've had it in for, 4 or 5 years, and they were stimulating 12 hours a day. They cut it down to 4 hours a day. They cut it to an hour a day, and now they stimulate 2 or 3 hours a week, and so because of that carryover effect. So it becomes personalized medicine. If you need more stim or if you're having a flare or something, you could do it. But if you don't, then you can just, stim when you could cut it out so you don't feel burdened by that antenna and that external device all the time. And so I, I like the idea of having an internal device because the patient doesn't have to think about it every day, do anything. It's just doing something behind the scenes. But there is some benefit of not having have that battery in you and that that feeling that underneath the skin. And I have the same issue with Curonics that I have with the Medtronic device, which is migration. And because neither of these devices are designed to be placed at the pudendal nerve. Now there's 3 companies out there right now working on pudendal neuromodulation, interestingly for not pain reasons. But it may give us some devices that are designed to be at the pudendal nerve that might be more reliable that we can, use in these types of cases with the appropriate lead and everything. But migration, because when these migrate, they almost always migrate deep. When they go deep, they go away from the nerve. So this is where, again, it's like being super careful during that recovery period to try to avoid that migration.
And what percentage would you say of the patients do have lead migration? Is it
So
pretty significant?
the Medtronic device, it's about 8%, and the Curonics device is about 14% in our data.
Okay. Mm-hmm.
So you could be glass half empty, glass half full. You could say it's 90%, it doesn't, or but if it happens to you, it's 100%. So it doesn't matter. People just need to know it's a potential risk.
It's a risk. Yeah. And remind me one more time for the lead migration, do you go in and remove the lead that breaks off, or do you fix the lead that migrated?
So there's a difference between a lead breakage and a lead migration. Migration means it just moved away from the nerve. So you pull that one and you put a new lead in at the nerve again. If let's say somebody had a Medtronic device in for 10 years and I'm trying to take it out and it breaks, or I have to replace it because nowadays they're MRI compatible. In the old days they weren't. If somebody needs an MRI, if it breaks, I just leave that little piece because to get that out is a big surgery, sort of like pudendal nerve entrapment surgery, right? You'd have to get down to there. And, we published a paper a few years back on, placing these electrodes on patients who've had previous PN surgery, where they go transgluteally and open the sacrotuberous ligament. And what we showed is that we were always able to get a lead to the nerve because once you operate on that nerve, they're lateralizing it, they're wrapping it, they're doing things to try to prevent the nerve from being, entrapped or scarred. But we've never not been able to be successful at doing it. I'm a big fan of neuromod. Like I would always say neuromodulate before, operate before having a big procedure like that. I've got in debates sometimes with Dr. Hibner and others of kind of best approaches to things. Obviously, there's no right answer in any of it. And we're all in our own biases, right? Because I see tons of patients who had pudendal nerve entrapment surgery who are no better or worse. but I'm not seeing all the ones who are doing well because they're not going to come see me. So in my mind, oh, that's a BS surgery. And, it may be the same with them. They're seeing somebody I operated on and this didn't work for them. And they're like, what's Peters doing there in Michigan? So we have our inherent biases based on our patient population and what we do and what we see. So.
All right. And then just out of curiosity, because the other one that gets talked about a lot in our group is the DRG.
Yeah.
And do you do DRG as well or no?
No, so DRG is typically done by like either, a lot of times anesthesia pain doctors will do the trial of a DRG, but it's often like a neurosurgeon who puts them in. So that's more like higher level stimulation. If it's true PN, I think that you're better stimulating the pudendal nerve directly because with a DRG, it's finding that sweet spot that picks it up where with pudendal nerve, you're at the nerve, right? If that's the problem, you're there. So I have had patients who had previous DRGs. I've had patients that have a DRG stimulator and a PN, a pudendal stimulator and they think both of them give them some benefit. I mean, whatever helps, right? I mean, in the end, what we're trying to do is just improve people's quality of life. I wish we had that magic wand to make it all go away. But, what we try to do is we try to kind of think outside the box, what can we do that isn't just standard care? It's like, you can't look this stuff up in textbooks, like, oh, this is how you treat somebody with PN because no one has a good treatment. It's like, how can you chip away at the triggers? And again, that's the whole looking at the whole person and not just, their
Exactly.
nerve and see.
And everyone's different, right?
Everyone is different.
Different triggers. And I
Yep.
know some people have certain symptoms, not others.
Yep.
It's varies so much. And is there any other specific criteria that you need before you're considered for a STEM? I know
Yeah,
some. Sorry, go ahead.
No, it's a good question. The biggest barrier always is insurance. If somebody has Medicare, I can always get Curonics approved, and I would say 3 years ago, if they had Blue Cross or other kind of private insurers, it was pretty well covered. But man, they have just made it much, much harder for us. So it is an insurance driven thing. You certainly have to document, that they have nerve related pain. You have to name the nerve. You have to demonstrate that they've had a temporary benefit from like a block. So that suggests this. But insurance companies can do what insurance companies want to do. I mean, they put up barriers all the time. For those who have the wherewithal, some people just decide to pay cash for it, but they're stupidly expensive because of the cost of the devices. And for the Medtronic device, I don't put that in somebody unless they have some urinary or bowel reason to justify the device because I can't put it in for pain alone. So you're putting it in for an indicated reason with their device and then really hoping that, pain, they get that benefit in pain at the end.
And then I know you also had one other device you were going to show.
Yeah, so the other device is so probably a lot of people with chronic pain know of TENS units. You can buy them on Amazon. They're like $30. They're like a little device, sends electrical stim. There's pads, and people put it if you have back pain, you put it where your pain is. All it does is sends a signal that kind of scrambles your pain signals that you have, but it doesn't penetrate through the skin. The energy from a TENS unit can't get through the impedance of the skin. Doesn't mean it doesn't help some people by being distractive of their pain that really bothers them. But there's another device that we've been using for a number of years now. It's called the BioWave, and they have like an at-home unit. It used to be like an office unit, but it's called the BioWave Go. I don't know if you can see that. But it looks like a TENS unit. It's a little device and it has patch electrodes. The difference is with this device is it has a super high frequency stim to get through the impedance of the skin. And then it has two different sine waves. So the stim slows down underneath the skin. That device is really designed for back pain, shoulder pain, knee pain, neck pain. And it works great for that. I have back issues and I'll wear that and it's like unbelievable. But for patients who have like PN, and and if they're willing to stimulate at home on their own, I'll have them purchase one of those. And depending on where their pain is, it's really about getting to the pudendal nerve. And there's a few places you could put this to get to the pudendal nerve, because there's that rectal branch of the pudendal nerve, right? So if you have these patch electrodes, and I think, yeah, I have, hang on. So the patch electrodes, look something like this, and there'd be two of them because you need to create a circuit. So you have two patch electrodes. So what I'll tell patients is put it on like each side of the anus, like on the inner aspect of your ischiotuberosities or your sit bones. And what you want to do is if you put them there, you want to stick like a rolled washcloth or something between there, because you don't want these touching because they could get hot. And so you put it there, and if you just turn it up, and what you're doing is trying to pick up the rectal branch of the pudendal nerve. You could put it another superficial place of the pudendal nerve is the clitoris or the penis. So I'll have people put it like one on the clitoris and like one in the perineum to create a circuit, or even perineally, like on each side of the perineum between the vagina and the rectum, or the scrotum and the rectum, placing them there. And I just will have them stimulate every day for, a session is 30 minutes, but you could do it multiple times during the day, or you could pick those different places. It is, you control the stimulation. It should never hurt. Like you're turning where you're definitely feeling it. And a lot of times, you'll feel it travel towards the side, the kind of the branches of the pudendal nerve. But it's just a way to kind of at home do something that doesn't involve coming here, getting an implant put in. And again, like everything, it doesn't help everybody, but it does help a lot of people. And if you have any associated back pain or anything like that, it's great for that too. So it kind of gives you a twofer. Unlike a TENS unit, which is like $30, I think these are around like $499. You could buy them with HSAs and things like that, but they're a lot more expensive because of the technology in them. But that's the other thing that I'll talk to patients about, and they decide if it's something they want to do or can afford to do. But it's always about just trying to figure out what else you can do to kind of change the signaling and override those abnormal signals.
And I know you mentioned earlier that there's a few advancements being made. Do you know specifically what they're trying to change? Is it the lead migration, the battery size?
So the advancements that are like the companies out there looking at the pudendal nerve are creating devices specifically to put at the pudendal nerve. So migration is certainly one of them. Approach to place it, greater coverage of the nerve, but the companies out there are looking at different things. Like some is for like neurogenic patients who can't urinate, to see if you can stimulate somebody who can't void to void, or people who have like mixed incontinence where they leak if they cough, sneeze, and strain and have urgency. So there's several companies out there that are looking at different approaches, designing different leads. Most of them talk to me because I've done more of these than anybody, and they want my opinion on it. So hopefully, if there's a pudendal nerve specific device that comes out, maybe more clinicians will do it too, because now you'll have a company that can promote it and sell it. Because right now, Curonics, although is approved for peripheral nerve pain, you're not going to see anything on their website for it because nobody does it but me. Now, that being said, their CEO just called me recently. We got a meeting next week. We're going to talk about maybe looking forward in the future of developing some specific approaches to the pudendal nerve. So I'm happy that they actually reached out, because they know I've been doing this for a long time. We also put on courses. We just had a big neuromodulation course in the fall. We have clinicians come from all over the world to it. And it's both didactic courses and hands-on, like cadaveric lab courses. And we teach people how to put in these electrodes at the different nerves and using X-ray and how to use EMG and nerve conduction. So we're always trying to educate people. We put on pelvic pain courses. We have one coming up this October where we get, a lot of APPs coming and physical therapists and physicians to talk about like our approach to pelvic pain and what we do in the Women's Center. So we're always, like, I feel like, unfortunately, and I get it. I mean, most clinicians don't want to deal with pain because it's a pain. I mean, we aren't confident in how to treat it ourselves. It isn't like, here, take this and it's going to go away. And the time investment involved is significant. So developing a center like we did, like if you came and saw our nurse practitioner for a new patient visit, you would have like 90 minutes with that person, as opposed to a 10-minute visit when you go see anyone else. So having that ability to invest that time and effort, and then, we look at other alternative things. Like we had gotten one of those magnetic chairs, those Amsela chairs, that people use for incontinence and for voiding dysfunction and sexual dysfunction. And, we tried to do a pelvic pain thing because it stimulates the pudendal nerve. Um, but the stimulation was just too painful. Like we tried to change the stimulation, but we did a handful of patients and we didn't make anyone permanently worse, but we weren't making people better and it was uncomfortable. So we're always kind of trying to think of the next thing. Our big thing we're doing now that we weren't doing a year ago is something called soft wave. It's a shock pulse system, a shock wave system. I don't know if you've ever heard or seen of it, but shock waves are what we use to break kidney stones since the 1980s, where you put a device against somebody's flank, you can focus a shock wave through their skin to a stone and break the stone. And in the 1980s, when this got developed, the FDA appropriately said, well, if you can break a stone, what's happening to the kidney, to the bowel, to the rib cage, every other organ that it touches? And so there was lots of studies looking at that. And what they found is that anything that touched the shock wave actually showed benefit. It improved nerve function, improved blood flow, and it activates genes that bring stem cells to areas of inflammation. So there's been different iterations of this device over time. There's tons of published papers, most of them not for like pelvic pain type things. Orthopods were using it for shoulder pain, knee pain. It's used a lot for like diabetic ulcers in the legs because it improves angiogenesis. There was a great paper just published from cardiothoracic surgeons where they did open heart surgery, and half the patients they did shockwave to the heart before they did the open heart surgery, and half the patients they just put the device on it and didn't activate it, and they biopsied the heart before and after the shockwave, and then they did their open heart surgery, and they found that the group that got the shockwave had so much better cardiac function than the group that didn't. And when they analyzed the biopsies, they showed these genes that activating that, again, improved blood flow and stem cell attractants. So, the focus of this company, the software company now, is around pelvic pain, pudendal neuralgia. So we have a device here. It looks like an ultrasound probe, and you put some jelly in it, and you put it, and we use it mostly in the perineum, so between the vagina and the rectum, to pick up the pelvic floor muscles and the pudendal nerve. And it's not like an electrical stim or anything. It's like a little pulse wave that pulses in there, and it feels like somebody's like just flicking you. That's what it feels like. But as you move it around, if there's an area that's inflamed, like your pudendal nerve or the muscles around it, people go, "Ooh, I feel that more." And it's never painful because we adjust it to your comfort level. But we've now been treating a ton of patients with this, and a lot of patients with PN have associated pelvic floor spasms and trigger points. Like when you do this treatment, and if you do an exam just before and just after, like the muscles feel like ice cream afterwards. Like everything relaxes, and so there's usually an acute effect. And we just presented at SUFU meeting, our the impact of this in both men and women. But what you really look for is you look for a benefit like 3 months later, because if it's working on a cell level by activating genes, that's not going to fix you overnight, right? That's going to be a continual improvement. Again, doesn't help everybody, but it's been a great adjunct to the other things that we do. And our physical therapists, when they first saw it, they're like, this is BS, but now they're using it all the time too. I'm like, I'm going to put you out of business with this device. But so again, we try to look at devices or technologies out there that maybe are out there for other things and try to say, how can we study it or look at it as an option to try to manage difficult conditions like PN, because there isn't anything off the shelf to just say this is what you do.
So I'm gonna ask if anybody else has questions. We did get a couple. So in the very beginning, we mentioned medications. Are there specific medications that you tend to lean towards? And then do you do things that are a little bit less common, if you will, like LDN, for instance?
Yeah. I'm not a huge medication fan because they have side effects, so you take one problem and you create another. Uh, I mean, we certainly will try things like gabapentin and Lyrica as nerve things. We'll use like muscle relaxants like intravaginal Valium or Xanaflex or tizanidine as a muscle relaxant. Um, and amitriptyline sometimes because we know for years it can help chronic pain. Um, but you know, you titrate those up enough where they help, and then it's just like, you're tired all the time. It gives you brain fog. I mean, there's other downsides. So my goal always is it's a bridge maybe, but I'm always looking to try to like see if we can get somebody better and try to get off of whatever medications they're on as opposed to on them. I don't have any magic bullet medication that I think, oh, this is great and you should take this. Um, and so I would say I'm less, I'm less, using medications. Most people who come to see me, they've already tried a bunch of that stuff, or they're on, 1,600 milligrams of gabapentin already. And I'm like, well, is it helping? And they're like, well, I don't know. And so if we get somebody better, then we work to slowly titrate some of these things off, because then I think your quality of life is better.
Yeah, definitely agree. Um, uh, Someone's asking for the name of the device that you spoke about. Is it Shockwave?
Well, it's Softwave is the name of the device. So if you just Google Softwave, they have a website. The website's really cool because every published article ever on this technology is on their device. I mean, it's been approved, oh, not approved, but I mean, it's been used for years, like for erectile dysfunction in men because it improves blood flow and nerve function. And there's good sham controlled trials on a lot of this. We're writing an NIH grant application right now to study it for pelvic pain with the sham to just prove that it works. We're fortunate here. The limitation of like Softwave in most places is cost because you can't build an insurance company for it. So people, it's typically out of pocket, $400 a treatment or something like that. It's usually 6 treatments. We were fortunate. We had a donor buy the device for us, which is like $100,000. So the health system lets us just bill an office visit for our time since we're not trying to recoup our investment. And so it's allowed us to treat, many more patients, and it's not like a wallet biopsy, depending on how much money somebody has, or putting somebody at a risk of, spending a bunch of money and it may not help them. So, we're fortunate here, but in most places there's some cash pay component, but it's also found in like pelvic floor physical therapist offices. Some chiropractors use it too. So it's trying to kind of find clinicians around you that might have some of those things.
So I'm going to read this one. I'm not sure actually what this is. So it says, have you tried peptides at all? I think that means to lower nerve inflammation.
Yeah, so it's funny because somebody just sent me a link, and to be honest with you, I haven't read it yet about that exact thing about peptides. And basically, it was one of my residents who saw some article come up, and he was joking with me. He said, "This is going to put your Softwave out of business," And there was there's a lot online about these specific peptides. I'm not an expert in it. I actually haven't even read it yet. It's still it was literally 3 days ago. And so it's on my docket to read at some point, but I haven't tried it. I know people go a lot of places and they do things like, they'll go get, PRP or stem cell injections and all this. I think everyone has to just be cautioned that there's very little, like I'm always a show me the data kind of person. That's why we publish a lot. We do a lot of research because when somebody has chronic pain, you become desperate and you'll try anything and you'll pay anything if somebody says that this is going to help you. And you just got to always put in perspective, you know, what's the likelihood it's going to happen? What's the potential downside? And at the end, the kind of potential cost benefit ratio, because there's a lot of patients I see go all over the place to get kind of really outside the box things done. And it doesn't mean it doesn't mean it couldn't work. It could, but you got to go into it with open eyes and ask the right questions of, like what impact that they've seen and how many of their patients get better and what's the long-term, effect of some of this stuff and things like that.
So we mentioned earlier that a lot of times pelvic floor dysfunction, ISPAD also kind of, are usually in the mix. What about CRPS? Do you see a lot of patients with CRPS?
I mean, chronic regional pain syndrome. I mean, it's kind of like you see it more in people who've been suffering a long time with chronic pain, right? It becomes an upregulation, because the concern always is, does the pain become more centralized pain, you know? So even if you fix the pain thing, it's sort of like phantom limb, right? Somebody gets their arm cut off, but they still have a pain in their arm, even though they don't have one. So CRPS is, I don't like, if you ask me how to diagnose it, I wouldn't have a good answer for you. But I think a lot of the patients I see have been like long-term pain patients, and the longer somebody had, like if I see somebody with PN who's had it for 6 months, I'm like, yes, you know, because I feel like that's a much easier person to reverse than somebody who's had it for, 16 years. And it just, I think that the sooner you intervene and do something, the better chance of reversing it. And I'll answer it because it's a good question. And just for those who maybe didn't catch the question, diagnosed with pudendal neuralgia, had pudendal nerve entrapment surgery in the past, still has pain. Could neuromodulation help? 100% it can help. I mean, not that it'll help 100% of the time, but it certainly can. I mean, that's a population of ours that we publish, papers on, that people have had previous pudendal nerve entrapment surgery, and we can, we've been very successful with getting a lead there. Whether it would help or not, for sure, don't know until you try, but I would certainly try.
The obturator internist, how do you know if this is your issue with PM?
I don't know how you know. I mean, there's I always think of the pelvic floor, like the pelvis is like a bowl, right? And the walls of the bowl are made of muscle, and there's different muscle groups, anterior, posterior, laterally. Obturator internus muscle sits right where the pudendal nerve. So through Alcock's canal, that's the muscle that it lies right along. So is it the obturator internus muscle, or is it just the pudendal nerve? And, because people always talk about the piriformis muscle too, because the sacral nerves come up underneath the piriformis muscle. So you hear piriformis syndrome. I don't know the chicken and the egg. I don't know if those muscles are upregulated because of, the pudendal nerve stimulate, pudendal nerve neuropathy, or if it can be impacting it as a trigger. So what I say is, I would try to do trigger points into the obturator internus or inject Botox into it, try to force that to relax, and then see if it improves the symptoms. But I don't know the chicken or the egg on that one.
And is there anything that helps with premature ejaculation due to pudendal neuralgia?
Interesting question. I mean, unfortunately, that's a common problem for a lot of guys, but I've seen it worse with pudendal neuralgia, and there could be associated PGAD with it, and the problem is to me, if it's really pudendal neuralgia, if you you know if you could do something to downregulate the nerve, does it change the sexual function? There's been multiple studies both on men and women of improvement in sexual function with neuromodulation. The problem always is it's like a secondary outcome measure. No one just does it specifically for like premature ejaculation. But we certainly have seen benefits in erectile function, ejaculatory function, female sexual function with neuromodulation. But is it because their pain is better, so they feel better? And I don't know how to know for sure if somebody has premature ejaculation. Is it the pudendal nerve driving that or not? And and I guess if they didn't have it and now they do, and they have PN, it would make sense to me, because I mean you have that branches of it that go there. So I mean I'd say you try to maximize treatment of the PN and see if it changes the sexual function.
All right. I think that's it for the questions. I'm going to give you guys 1 minute just to make sure that I didn't miss anything.
Somebody said, what is PGAD? Good question. It's persistent genital arousal disorder. So what that means is like, it's like horrible, because, patients feel like they're on the verge of an orgasm 24/7. And sometimes they have multiple orgasms, like they'll hit a bump in a car and they'll orgasm, or they have to orgasm just to get that sensation gone. And they become almost hypersexual because it's the only way to get rid of that horrible sensation. And these patients who have it, it's like a miserable feeling for them. And some of those are definitely pudendal nerve driven, but there's other causes of it. And I mentioned at the very beginning, if you weren't on, there was a big paper published like 4 or 5 years ago in the Journal of Sexual Medicine. I was one of the authors on it that go through PGAD in detail and all the different areas that it could be coming from. It's a complex map, sort of like PN, to kind of figure out how to fix that. The weirdest thing about PGAD that just came up to me recently, because I have a couple patients who have it pretty intensely, is that I had a couple patients who started those GLP-1s, the injections for weight loss or diabetes, and their PGAD got markedly better. And then you start Googling it, and there's all these PGAD support groups of people saying the same thing. So I don't know what that means yet. This all just came up in the last couple of weeks, but it's something I want to kind of explore a little bit more and see what it because like one of these patients I've been taking care of for 15 years with PGAD, and it's been horrible. And she's just like, it shut it off. And I was like, for her to tell me that, that's pretty impressive, because it's been a hard needle to move before.
Okay, one person, oh, because we talked about the two different stims that you do, the
Yeah.
Curonics and Medtronic. Is there one that would make someone a better candidate for the other?
If you have no voiding or bowel symptoms, it's going to be Curonics, because I can't justify a Medtronic device, because those are really approved for that. If you have enough to justify an Interstitial implant with the bowel and bladder, and even though we're kind of pushing the envelope around the pain, I'd have an equal conversation about it. There's some people who, like the idea of set it and forget it and something's inside of them, and other people who say, I'd rather not have a battery in me, and I'm happy to just wear something outside my body. And it becomes kind of dealer's choice. I've done way more Medtronic than Curonics, because I've been doing Medtronic since 2003. So my personal preference is that, because it's where I'm most comfortable. And but I do think if we get kind of a device that's pudendal specific, and I'm excited to meet with the Curonics people next week to kind of talk about what their thoughts are, it might change my mind a little bit, that we can kind of create a lead and a package of treatment that might be more. I mean, right now it's MacGyvering everything. It's like it's like you take a device and you're changing it to suit the need of what I'm trying to do. So if you had something that had all the tools in it, and the tools are better than what we currently have, I might feel differently. So
And can a stim help PGAD, or would it cause overstimulation?
no, it definitely helps PGAD. We publish papers on that too. It can help PGAD if it's the pudendal nerve, And so what I would do with PGAD, if somebody's in a PGAD state, do a pudendal nerve block, and if their PGAD goes away with the block, then I would definitely consider a pudendal stim.
All right. And then there was one more, and I think this was mentioned earlier, but I can't remember. What is your view on, is it PRP? Is that the
Yeah, I don't have a view, because I don't really know. I don't do it. I mean, I have lots of patients who've gone and done it. It's people. I wish somebody would just do a study. Like I'm like, just do a study and prove to me that it works. I'm not saying it doesn't work, but I'd rather somebody do a study and prove it, and then is it worth the money that somebody's going to pay to have it done? So I don't have a negative thing about it. I try to caution patients to be careful, because it's very easy to kind of go down we try to put data behind everything we do, and I think there's a lot of people who just kind of open up shop and start doing stuff, and you don't know you don't know what their motivations always are.
So this one, I'm guessing might be too specific, but I will ask. For hypertonic pelvic floor after total hip replacement, what is the best course of treatment?
Hmm. I mean, I would treat it no different than I would treat anyone. I would, do pelvic floor physical therapy, probably add soft wave to it, and do trigger point injections and pudendal nerve blocks as part of the management. And, big fan of like stretching and yoga. There's a particular yoga called Yin, YIN yoga. It's all deep stretch yoga on the ground. So it's not crazy poses where you got to move around. It's just literally on the ground yoga. And it's really hard yoga, because you stay in one pose for like 3 to 5 minutes at a time, but it lets your body weight slowly stretch out your hips and your back and your pelvic floor. You don't need an instructor. You can just Google it. There's lots of videos out there. It's just having the patience to stay in one spot for a long time, to really let the weight of your body, you know, change the muscles.
Well, this one's interesting because we didn't mention this one. What is your opinion on the Sprint pain pump to try to reset the nerve?
Yeah, so Sprint's not a pain pump. So a pain pump is like an implantable device where you actually could put chemicals in the spinal column to the nerves, like an anesthetic or an opioid. Sprint is a neuromodulation device that you place at a site of pain, and it's externalized. I mean, you do it for 60 days and it's removed. The concept behind it is what I said at the beginning about this carryover effect. If you stimulate continuously, and that's where I was saying with the BioWave 2, that external device you could buy, if you stimulate continually, you may be able to change the course of the stimulation even when you stop. I think Sprint is the reason why I'm having trouble getting Curonics paid for, because they trained all these people to do this simple device and they started using the same codes that we were using for Curonics, which wasn't appropriate. So Blue Cross and all these insurers saw utilization of those codes go up dramatically, and they just stopped it all because they're like, what happened? Like, we weren't having all these codes used and now they're being used all the time. I think that I think if it does help, at some point it's going to come back again, and that's what we typically see with neuromodulation, is that you get a carryover effect. And we see it like with tibial nerve stimulation for overactive bladder. That's why you could do it once a week and, to stimulate the nerve in your ankle to treat overactive bladder. And then once a month after you get better to maintain it, because there's a carryover effect. But I think, the concept is interesting, but I don't think it's going to be one and done. I think you're going to have to do it again.
So I can't be sure that they meant the Sprint one or the pain pump. So I'm going to ask a question.
Yeah.
What are your views on pain pumps being used?
It's interesting. I don't see them used nearly as much now as I used to. I used to have all these patients coming in. I always liked the concept of it in people with severe intractable pain, because you could titrate the medications that are going in the spinal column, and to me, what you want to do is maximize the anesthetic, but it's that balance between enough anesthetic to numb the nerve and let you still walk, right? Because if you overdose it, you're just going to be numb and not be able to do anything. So it's finding that titration. And then you could add opioid, and the amount of opioid you need, if you put it there as opposed to taking it orally, and as it gets processed through your body, becomes much less. So I've definitely seen patients who just, like, nothing has helped. They're bedridden, their pain is horrible, PN or no PN, whatever. It's just some chronic pain that, I've seen these be beneficial for them. But I don't know what happened, because I feel like in the last 4 or 5 years, I'm hardly seeing anyone putting them in anymore. So I don't know the backstory on it, but I like the concept of it if you were going to needed to do something, more.
And is this something that the clinic where you work, do they do pain pumps, or is it something that you would have to go to a specific?
Our anesthesia pain folks, do them. But again, like, I don't see them done very much anymore. I don't know if it became around that whole opioid thing. I don't know if it's about reimbursement or getting insurance approval, or just the work effort of trying to titrate, because, patients got to come in, you stick a needle through the skin to fill the device with whatever, cocktail you're putting in there. And I don't know if it just became, I don't know what happened. Actually, it's an interesting question, but I was thinking about that recently. I'm like, man, I just don't see them like I used to.
So I'm going to end on this one. For the yoga that you mentioned, the yin yoga, is it safe to do for someone who is hypermobile?
I mean, there's hypermobile and hypermobile. I think you do it in the constraints of your body, just like if somebody isn't hypermobile, you got to be careful you don't, like, overstretch things too quickly. Like, it's tincture of time and do it. But I think it would be safe, but I'm not like a structural medicine person. And I would say just do things gently and lightly and see how you do with it. But I can't imagine why it wouldn't be.
All right. Perfect. Well, thank you so much for doing this for us. I
Oh,
think
you're
this
welcome. Hopefully it
is
helped.
educational